how to approach a first session with someone experiencing psychosis. So before going there, thank you, Nina, for that fabulous introduction. And let me give a word of thanks to all our collaborators and supporters. We are affiliated to the Yale School of Medicine. We are supported by DMHS. We are supported by NIH and DCF. And the STEP Learning Collaborative is the statewide initiative. We are trying to build up a learning healthcare system for first episode psychosis. So without much intro, I will go straight to the session. This is to approach a first session with someone experiencing psychosis. One minute. Oh yeah, here it is. Okay, so when we are talking about a first session, 1 minute, okay. So there are certain assumptions we are keeping in mind. So sometimes the first session you could be called into an intensive care unit when the person is medically stable, or you are talking to a patient who is in ER, who's very aggressive or disorganized. The person may be catatonic. We are not talking about such first sessions. Okay, we are talking about a patient who's coming to you in your outpatient clinic, or the person could be hospitalized, but that person, the individual, is stabilized, and now the treating doctors and nurses, the medical team, has asked you to evaluate the person. Okay, now, so our assumptions here is the person is medically stable. The person is not actively suicidal. The person is not aggressive. The person is not in a substance intoxicated or a withdrawal state, not extremely disorganized or catatonic. These people all need, these people who are suicidal, aggressive, all these people need psychiatric help. But dealing with them in a first session would be it would be a different talk. The approach would be different. And also, we are not talking about people who are having psychosis while also suffering from intellectual challenges or autism, because they need more focused, more specialized approach. So in all practical purposes, we are thinking about a person who's coming to you, who's willing to talk to you for 30 to 45 minutes. They might be willingly coming for it, or they are doing it just because their doctors or nurses told them to do, or they are there just out of politeness. Whatever be the case, they are there to talk to you for the next 30 to 45 minutes. So these are our basic assumptions. Now, even though they are not unstable, they may still be experiencing psychosis. So they may be reacting to their symptoms. So you may see them muttering to self. You may see them looking here and there. You may find them very paranoid about the hospital staff or even towards you. And regarding the psychosis, regarding the symptoms, their insight could be anywhere along the continuum. Some might be having good insight. Yes, I'm having these symptoms, they are distressing and I need help. Some might say that I don't have any problem, and it is it is 1 minute, I'm not able to, so there could be anywhere along the insight continuum. I mean, some might be saying that I don't need any help. So it is important to consider that they have their own unique psychopathology at this point of time. And at this point of time, we should also think that the person should be having an access to a prescriber. So especially if you are seeing a person in an inpatient unit, there could be situations where a prescriber or a psychiatrist might join you, especially when the impending discussion includes medication safety. You wanted to include, for example, your patient is on risperidone, and the patient want to discuss about this risperidone, and the patient want to discuss it with you and the prescriber together. So there could be a situation where a psychiatrist or prescriber may join you in the first session, but it may not be the case all the time. But it's important that the person should have an access to a prescriber. Okay. Now, the most important thing which we need to consider is each person is unique. like how every human being is unique. Each individual with psychotic symptoms are unique, and each person's psychotic experiences are colored by the unique contents and forms of their psychopathology. They might be having delusions, and it could be anything, weighing from FBI chasing them to someone doing a black magic about them. It could be culturally colored. Okay, it could be colored by their life experiences. It could be colored by their temperament. So meeting someone if with psychosis for a first session is in that way, it's not very different from meeting someone, any human being, professionally or socially, because what we want to know, what we want to do in any first meeting is to make sure the person is comfortable, treat the person with respect, build trust, and there should be some level of autonomy for the person. So that's what we want to practice in this too. The person with psychosis should be treated with respect. There should be an amount of trust. There should be a level of autonomy for the person. So if we consider this person as a unique human being and we are willing to actively listen, our job is going to be easier. Since each person is unique, so there is no one size fits all template for us. Okay, many a time we will have to improvise as we go. But these are certain, overviews which we can look into. The first thing is introduction, a greeting, and in the US, we know it's always handshakes is the way. But if you work in South Asian countries or something, handshake may not be the way, and the way you greet a person may be depend on their age, gender, and all those things. So find something which is socially acceptable for the society or the community which you're working in, especially if you are not working in a Western population. Introduce yourself like I'm Deepa and so. I'm working as this. And if you want to, you can actually tell them what you want them to call you, and make sure you get their name right and how they would like to be addressed. They might have a name just on their certificates, but they might go with a nickname or an abbreviation of their name. So make sure you know how they would like to be addressed, and make sure they are comfortable. Do they want a glass of water? And if it is in your hands, make sure the room is pleasant. It's well ventilated, well lighted, but not too bright. Overall, the person should be comfortable. Like, certain times those things are not in our hands. How the room, whether they are ventilated or not, so some things may not be in our hands. But but make sure we are making the person comfortable to the best of our ability. So once we greet the person, the individual, the next thing is to enter into a conversation. So how do we enter into a conversation? And here, more than your psychiatric interview skills, the thing which is going to help you more is your general conversation skills. So we will have to actively listen. Like many a time when we talk to patients, we as in some, at least some of us, because I have made this mistake before. Like I would be thinking about, okay, what psychopathology I'm going to elicit, what answer should I give, and I might be constantly thinking about what answer would I give to the patient or the patient's attendant, which is one of the biggest mistakes I think I have made. So only thing we have to do is actively listen here. So try to befriend them. So focus on safe topics. So what do? Are they going to school? Are they working at least part-time jobs? And sometimes what they say may be of interest to them. If someone is saying that I love movies, I would be like, oh, nice. I like. Is there any movie which you would like to see in the future? They say some movie. I'm like, oh, I have seen that, or something like that. Now, or their pets, the vacation places they have gone, their hobbies, and we may not know anything about those things sometimes, and we can try to learn from them and highlight the strengths, and try to find a very likable quality and genuinely appreciate. Maybe they are planning to go back to school in the fall. Good. Or even with all the symptoms, and they're trying to they're managing to do a part-time job and they are earning some money. Yes, like appreciate that, genuinely appreciate, or the very fact that they have come for a session with you. So find a likable quality and genuinely appreciate, like what is a strong quality of them rather than focusing on what is wrong with them. So we go through this. And so this is an example I've kept. If everyone can see the screen, I'll let you guys read it by yourself. I'll give you like maybe 1 minute or so to read this. I hope everyone has finished reading. And this might be a conversation which many of you might have, faced while you are talking to your clients, patients. So, so when someone is talking, so here there's a person who's talking about their job or their hobby or their interest, and then shifted to their psychopathology. So, but if we don't know what they are talking about, it's always it always fine it's always good to be genuinely curious. Oh, I don't know this much about physics or anything. Could you please explain this to me? Or even when sometimes when they talk, you're getting a hint that this is a psychopathology. This is part of their symptom. But appear genuinely curious. Could you explain this to me? Okay. Oh, how do you know they are tracking you? Oh, that must be scary when you feel tracked all the time. So by this time, you know that it's part of their symptoms. They're talking about a delusion. Okay. And at this point, we don't want to argue because arguments are already done. Their parents have argued with them, their friends have argued with them. Everyone had tried to give them 100 evidences that, FBI is not tracking you. Okay. They're not tracking you. That part is over. If they would have gotten better by those kind of arguments, they would not be in a hospital or in an outpatient clinic. So we cannot argue with them because according to them, this is the reality. Okay, when you become psychotic, your perception of reality changes. So this is their reality. We cannot challenge their reality, but at the same time, we cannot reinforce their belief. We cannot say that, oh yes, I agree to you. I think they are tracking you. We cannot say that too. What can we do? We can connect to the emotion, the fear, the anxiety that someone is tracking to me all the time. We all can relate to that fear, that frightening feeling. Emotions are something which we can always relate to. So relate to that emotion. Oh my God, that must be scary when you feel tracked all the time. Now, this is one way when someone talks about their interest or hobby, they shift their symptoms. Now, if they don't do that, we can initiate the conversation. So you're talking about their hobbies, their life, their jobs, and everything. Any change in the functioning which has already come up in the introductory talk, they may say that they have dropped out of school, or they have lost their jobs, or they're not hanging out with friends anymore. So how so? What happened? They may say this. They talk behind my back all the time. Now, one thing we have to be sure about this time, this may not be a delusion at all. Okay, there is a chance that people are talking about them behind their back. There is a chance that, some family member might be trying to harm them. So there are situations where what they say may be a symptom, it may not be a symptom, but that that elicitation of whether something is true or not, so whether something is truth or a delusion, that we will get to know as we talk to them more. So sometimes we'll be able to elicit the morbidity behind these beliefs. You will get to know that more. But whether it's truth or not, whether there is a chance that people are talking behind their back or not, it's always important to express our empathy, validate their emotions. Or we can also nudge towards recent events. They were hospitalized recently. There was a ER visit. So what happened? Okay, they may say that, oh, my mom took me, she was scared, I don't know what happened, and the doctor's given me injection, then they shifted to the ward, all those things they will say. So Again, that must be very overwhelming. What happened? Are you feeling better now? Then they may say that, yeah, I can, maybe I'm sleeping better, or my anxiety has come down. So that gives us a place. Yeah, okay, coming to the hospital, everything was overwhelming. But the anxiety is a little bit better. Maybe improvement in your anxiety, being able to sleep better. That is something which we can think about, which we can work towards. Okay, that gives us a place to start. Or at some point, they may not have any insight at all. Like here, like my dad and mom thinks I'm crazy. I don't see any problem with me. I'm perfectly fine. I don't know why I'm in the psychiatry ward in the first place. So this person is obviously frustrated. Frustration is something which we can all relate to. So we can go there. I can imagine the frustration, especially everyone is disagreeing with you. How are you feeling now? So, all these places, we are doing the same thing. We are finding the emotion, we are validating. We are finding the emotion, we are being empathized. We are expressing our empathy in a genuine way, And we are actively listening, we are genuinely curious, we are empathizing. This is something which we are doing again and again and again during the complete session. And oh, another way. Okay, so we may see that the person is muttering to themselves. I just noticed that you are muttering to yourself, or you are looking here and there. Is there anything that bothering you? Then they may say, oh, I could hear the people, other patients in the ward, they are talking about me. They are planning something against me. So this is another way. Now, when they talk about the symptoms, the psychopathology, so it's very important to be in the patient's shoes, because again, when they become psychotic, the psychotic world is their reality. Okay, so they are feeling the fear, they're feeling the anxiety, everything. So try to imagine yourself in their situation. Okay, someone is watching me. That must be frightening. It's not easy to live with that experience. Could you tell me more? When does it happen? How do they feel? What do they do? Always express genuine curiosity and empathy. And at any point you feel that the person is not comfortable talking about it, it's okay. We can always take a step back. If they're comfortable, let them talk. If they're not comfortable, respect that and take a step back. And as we already said, it should always be non-confrontational, non-judgmental. They might have beaten up someone when they are during their psychotic break, or they might have abused substances when they were in the psychotic break. We are not going to judge them at this point. And preferably open questions. Tell me more. How so? What makes you think that? Because that gives us another path to go forward. Okay, or something like closed questions like, are you hearing voices? They may say no, and there ends the interview. So when we ask open questions, they may not even say about voices, they may say about something else, but we can actually listen, pick up on what they said, and go ahead with the conversation. It's more of a conversational skill than a psychiatric interview skill. So during all these procedures, we are establishing a rapport, a trust, a therapeutic elegance. And in your 30 minutes of your interview with a person, if that's the only thing you could establish, then you win. This is a win-win situation. You could not finalize the diagnosis, you don't know the entire psychopathology, there are many things you could not do, but you could establish a rapport with the person. The person trusts you, and you're sure that the person will come for the next interview. This is a win situation, the establishment of rapport or therapeutic alliance. And if you want to know more, we can take a CBT approach here. This is something many of you would have used to understand the symptoms of someone with anxiety or something. We can use the same thing here. For example, let's say the person is hearing voices. Yes, I may know a lot of facts about the voices. What is he hearing? What are the contents? But what is he feeling when he's hearing voices? He's feeling frightened or anxious or sad, distressed. the emotions. And they may feel panicky, they may feel palpitations, they may sweat, they feel very restless, the physical symptoms. And what do? They try to close their ears, they try to put headphones in their ears, they try to be restless, they want to, bang the doors, whatever they do, that's the behavior, and everything is affecting everything. So, if we understand every dimension of a symptom, especially the emotion and physical symptoms, that is where we can understand what the person is going through. When you ask this, the individual also feels like you're trying to understand them, they're being heard. And you also know that is there any precipitating factor and what are their behaviors. This gives you places where we can intervene. So taking this kind of a CBT approach will help, especially if you have time. Okay. Now, this is something, the next step is about finding a common goal. So we have already had a good talk with the individual. They talked about their interests, their hobbies, and everything. And what is preventing them for reaching a goal? For example, the person might want to go to a literature program, and they want to become a writer in the future. So there's an interest which is turning into a goal. And what is preventing them? The psychosis, the symptoms, the voices, the anxiety, the depression, the sleeplessness, all those things. And here, if we can connect this, so we know that the person has these goals. Okay, is his goal, what is his goal? Is it going back to school, or is it going back to job, or the goal being less anxious? So if we establish a common goal, that gives us another space to intervene. So establishing shared goals. It could be reduction of anxiety. It could be better sleep, better concentration, going back to school. And we should be careful to know that these goals are shared. It's not like my goal, it's not the clinician's goal. Okay. If the clinician's goal could be, reduction in auditory hallucination, but what is the patient's goal? The patient's goals could be this or something else. So it's important to establish shared goals. And once we have shared goals, we can work towards that. Like we can give very practical, individually tailored, flexible, practical assistance right away. The most important thing is right away. We are not postponing, we are not rescheduling the help to another session. If we establish a shared goal, give the help right away. How do we do that? For example, the person is saying that I feel extremely anxious during the when I hear the voice, what do I do? You know that if you're going to do CBT for auditory hallucinations, it's not going to happen in one session. You need multiple sessions to do therapy for auditory hallucinations or delusions. So that's not something you can give immediately, but you can give something for the anxiety which they feel. You can suggest them progressive muscle relaxation techniques. You can give them the audio narrative or other anxiety improving techniques which you already know. Deep breathing, look, point, and name. Describe with five senses. So the voice does not disappear, but the patient can handle the anxiety better. This is something which they would appreciate. Or if they are thinking about insomnia, secondary to psychotic symptoms, and one is tell them about sleep hygiene, and this might be somewhere you, especially with the help of a prescriber or a psychiatrist, can talk about the importance of medications, because when the person is extremely psychotic, sleep is going to be a problem, and when sleep is a problem, you know the psychotic symptoms are going to worsen. So if the person is a little reluctant for medications, this is where we can put ahead, maybe these medications will help you to sleep better, reduce your anxiety. So that is sometimes if you want the presence of a prescriber or a psychiatrist at this point of time, that is completely understandable. Or if the person has a habit of going for substance use, using marijuana or something, when the psychotic symptoms are too bad, okay, you want to help them. Talk to them about craving control techniques. Talk to them about harm reduction techniques. So these are things which you already use. anxiety reduction, insomnia, substance use. These are the things which you already use. These are not specific to psychosis, but these are things which you can immediately provide and that will help the person immediately. Then, most importantly, focus on their perspectives. Okay, psychosis, schizophrenia is a disease with multiple dimensions, multiple consequences in life. And as we said, a clinician's or a psychiatrist's uh, understanding or goal might be one thing. Okay, reduction, delusions, hallucinations, or something like that. But the patient, the individual might want to go back to school or hang out with friends, or they think that their dating life is not going well. So I want to improve all those things. I want to get a job. So focus on their perspective, because if they feel that they are not heard, they are not going to come back to the next session. It will be just a very painful exercise for them. So it's important that we focus on their perspectives. Okay, all perspectives are important, the patients, the clinicians, the parents' perspective. But we have to understand that this is a whole thing, psychosis, a whole thing, and if we have to focus on their perspective first and introduce our perspectives too, slowly. This is a third thing we are going to say. We have already established rapport. We have found shared goals, and we have focused on their perspective. And now we are going to normalize the symptoms. Okay. So how do we normalize? That experiences occur in a continuum. Voices, for example. All of us would have had some experience in our life. Someone is calling me, but no one is there. Or I heard something, there is nothing. I thought my phone is ringing, but it was not ringing. Or I just saw something like a shadow. Once in a while, people get such experiences, especially when we are tired, or especially when we are frightened, anxious, or sometimes hallucinations can occur just before when we are going to sleep or just when we are getting up. So these are normal. Then there are symptoms in a prodromal category where these kind of symptoms are more frequent, but I know that they are not true. Then there is a psychosis spectrum. So this is kind of reversible from normal to the prodromal stage to psychosis. Tell them that it is reversible. It's like both ways. And also tell them about the prevalence of psychosis. Schizophrenia, we know that worldwide, irrespective of the cultures or countries, the prevalence is around 1%. And you can talk about specific statistics of Connecticut. And we can also talk about the prevalence of psychotic-like symptoms in non-clinical population. For example, like almost 10% of the population hears, like they are not diagnosed of any illness, they go on with their lives, they have their own lives, they don't have any problem, but they hear voices sometimes, which is not distressing to them. So the prevalence of these symptoms is more common. Okay, and it can any age, any ethnicity, any gender. And tell them that there is hope, there is recovery, treatment is there, and with treatment they can go ahead with their lives and connect with others with lived experiences. There are peers, there are online forums, support groups, and talk about, people with lived experiences. There are individuals like Cecilia McDowell and many other personalities who are open about their experiences with psychosis and go ahead with and went ahead with very successful lives. So make sure that we are normalizing the symptoms, not catastrophizing, not thinking about this as a radical change, thinking about this as something occurring over a continuum. So, this normalization is the antidote to stigma. And when stigma is not there, people will come happily for, treatment. And this is something which is already proven about different diseases. For example, there was long time back, like seizure disorder, epilepsy was considered very stigmatic, and people were, looked down upon. It was the people were outcast. because of the presence of seizure disorder. But nowadays, people openly talk about it. People are okay to go to a physician to get treated. Similarly, we are thinking about a state where people are openly talking about psychosis, going to a clinician for therapy or medications and get ahead with their life. And normalization is the key here. And while normalizing, we are curious, we give practical support, avoid confrontation. This is something which, we have gone through again and again, but we are not colluding them. Okay, this is another technique which we can use for normalization, the stress bucket analogy. Some of you would have already heard about it. So the bucket, the size of our bucket, or how filled is the bucket, is our vulnerability. For example, if I have a family history of schizophrenia or bipolar disorder, then my bucket is either small or it's already a little full. And what is adding there? The stresses. It could be transition to college or conflict with friends, many pressures, substance use, the certain disruptions in social life. Everything is added. And when it overflows, what happens? I'm irritable, I'm having very intense thoughts, I'm hearing voices, I'm irritable, I'm suspicious. What can we do? We can poke holes in the bucket. So that could be our relaxation techniques, deep breathing, talking to people whom we love, listening to something which is soothing to you, going into exercise, physical exertion, therapy, medications. So this is something which we can tell them. So, we are poking holes in the bucket. So till now, what we have done is established common goals, focused on their perspectives, and everyone's experience being unique, we normalized, and we are providing practical assistance. So this is something which we do again. Keep paraphrasing and summarizing because we are going to talk a lot during the session. Okay, and it might be a lot of information for the person. So every now and then, say. So what I understand is the troubles with voices started around December. It was once in 2 or 3 weeks, then continuous. Am I understanding it right? Is it right what I'm saying? Then the person may say, yeah, but there is a correction. This gives them the feeling that they are being heard. Okay. And while talking to you, while correcting you, they will also get a clarity of what's happening. And while we are at it, we can also ask them about their explanatory model. Of course, as clinicians or psychiatrists, we always have a medical or psychological model of the illness, which is all good. But sometimes the person has their own model. There could be cultural model or models rooted in religion and spirituality. And you may disagree with their model, but you don't have to say it because we are not treating their model. So let's say a person believes in a model which is deep rooted in spirituality, but that individual is coming to you regularly for your therapy. The person is sticking to your the medications, and they are going ahead with their life. They are better. They are going for a job. No, then what they believe as a model is none of my business. Let them have their own explanatory model. This is not a time where we argue about the model. But in case if they ask, we can also say always say about the biopsychosocial model. So we have a biological vulnerability, okay, but it's not completely genetic. There are social and psychological stresses, everything coming together around the adolescence age, pushing the person to, certain atypical responses, which is essentially psychosis. So we can also do a little bit of psychoeducation. All these things which we have done now is essentially psychoeducation. Discussion on models, stress bucket analogy, the prevalence factors, discussion on medications, lifestyle changes, what to do in a crisis. We provide them with crisis response, hotline numbers. All these are psychoeducation. So whatever you talk to them, whatever information you are passing on to them, whatever suggestions you're giving them, these are all psychoeducation. And while we are talking about medications, antipsychotics are the first line treatment of psychosis, which is something which we all should know. Along with therapy, antipsychotics are going to be there unless There are certain situations where antipsychotics may not be needed. For example, the person is in prodrome, they haven't completely crossed over. Okay, then at the situations that the symptoms are attenuated, then you may not need an antipsychotic. Or the person is having a psychosis is purely substance induced, and the person is in abstinence, and you can see the symptoms are coming down, 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 down. Or there are going to be some people who are in complete remission after their first episode of psychosis. They're in complete remission. They might be tapered about all medications, but unless the individual is belonging to any of these categories, there is going to be antipsychotics, and such discussions are going to come. And please make sure that the person has an access to a prescriber or a psychiatrist, because they will have doubts about questions about medications, the need, the mechanism, the side effects. So you will need that expertise too. So make sure they have access to a psychiatrist or a prescriber. And if the first decision, if you think that the first decision is going to have discussions about medications, it is also a good idea, at least for some time, a prescriber or a psychiatrist is joining you for this particular discussion. And most importantly, we all know assess the risk. Check about suicidal ideations, aggressive impulses. Sometimes we have to ask. Sometimes we have to ask them and ensure that they are safe. And most importantly, ensure that you are safe also. Okay. And in a nutshell, we are coming to the end. So, in a nutshell, we have established rapport, we have established shared goals, we have given them practical assistance, we normalize the symptoms, we emphasized their perspectives, gave psychos education, we ensured safety. This is all we are going to do in the first session. And if we cannot do everything, still okay. If you established only rapport, okay, if you could only do rapport, shared goals, and give them some assistance on handling their anxiety and sleep disturbance, that's still good. Make sure this is where we make sure that they're going to come next week, okay, or they are going to inform me that if there is a crisis. And it's going to be individually tailored, because the fixing up the next appointment, all those things, we have to make sure that it's a bit, it has to be a little bit flexible, because most of your clients are going to be young folks. They may be 17 or 18. So they may not be okay to call your office landline and talk to your receptionist or secretary and fix an appointment. They might be okay to do it by text or something. So we can also be a little flexible in such things and make sure they have resources, you know, in resources to know what to do if they are in a crisis. And one thing we can also add at this time is how much they want to include their family. Okay, they are okay with it. Okay, so this is some conversation we can have in the first or second session. So to conclude, summarize the discussion once again, and ask if they have any questions, appreciate them, thank them for their time, fix the next appointment if possible. Okay, so make sure it's a dynamic back and forth conversation. It's not a didactic lecture. We are not sticking to a rigid questionnaire and asking them one question after the other. No, we are not doing that. It's more of a conversation with a person who has many interesting things to say, interesting but also distressing things to say, and you are in a situation to help them. If we see like that, things things would go easier. So by this, I think we can conclude